Good evening, everyone. I'd like to acknowledge the local custodians of the land in which we meet this evening and honour elders past, present and emerging. I'm Elizabeth Wilkinson from the Hunter New England Central Coast Primary Health Network. Welcome. We're here tonight with a very important topic, and I'd like to welcome you all and thank you for taking the time out to be with us tonight. A little bit of housekeeping. Just a reminder that you can pop any questions you have. This is your opportunity to ask those questions, and you can pop them into the chat or questions box, and the presenters will get to those at the end of the session. So I strongly encourage you to do that. This is your opportunity to ask those questions that you've been wanting to ask. And secondly, we will be recorded this evening, and it will be available on our education library to reference as a point for later on. I also encourage you to answer the questions in the poll that will come up and pop up. It'll only take a couple of minutes, and we strongly encourage you to do this. That provides us with information and data to help us plan further education events. We really find that valuable, and I strongly encourage you to complete that as well. I'm going to introduce our speakers for this evening and thank them. Three of you for being with us this evening. Welcome. I have Olivia Greggs from the Clinical Nurse Consultant for Child and Adolescent Mental Health Team with the Central Coast LHD and GP Liaison Officer. Welcome, Olivia.
Thank you. Welcome, Mel. Thank you very much.
You're welcome. And Dr. Kevin Tang from Gosford, the Gosford Mental Health Acute Team. He's from the Psych Advanced Training Team as well. So welcome to this evening, Kevin.
Thank you for having me.
You're welcome. And finally, Erica Drew. Welcome, Erica. She's from the PHN with us, work based on the Central Coast. She's with the Central Coast Health Pathways Manager. Thank you, Erica, for being with us this evening as well.
Thanks, Mel.
I'm going to hand over now to you, Olivia, to start your presentation. Thanks, Olivia.
Thank you, Mel. Hi, everyone. I'm Olivia Gregg. I'm the Clinical Nurse Consultant for Child and Adolescent Mental Health Services, as well as the GP Liaison. I'm certain that I have spoken with a fair bit of the GPs on the Central Coast, and I hope I've been helpful in any of your inquiries. What I'd like to do tonight is just briefly talk about what support services are available in the community for the young people on the Central Coast. I've been asked recently by a few GPs about what services can they refer families or young persons out to. So I put together a list of services that are the most appropriate, but there are many more other services. If you are in doubt, just give me a call. My mobile number is on the Health Pathways, and I'd be more than happy to do the legwork for you and find out what the needs are and what would be the best service for your patients and their families. So I'll start with Headspace. Headspace is part of New South Wales Health, and it looks after young people, or it supports young people between the age of 12 and 25 that have mild to moderate mental health concerns. Sorry about that, people. They usually complement us. We work on the moderate to severe mental health. They work on the mild to moderate. They are Monday to Friday, and they're based in Gosford and in Lake Haven. They offer holistic care for the young persons. They offer counselling services, linked to other services in the community, and support to the young person and their families. Headspace and CAMS we work closely together. Sometimes some GPs will send a referral both to Headspace and to CAMS, not knowing which would be the most appropriate service. I always assure the GPs that if the referral is accepted by Headspace, and if at any point they feel the risk is too high for them to manage, they will always liaise with CAMS, and CAMS will take over the care of their client. We do have a weekly meeting between CAMS and Headspace where we transition clients. We can step up the care where they can come to CAMS, or step down the care where we hand over to Headspace. And that's the beauty of working closely with Headspace, between Headspace and CAMS. The other service, which is really quite important and is becoming quite relevant nowadays, a few GPs have asked about it and mentioned it, is sexual assault services, what we usually previously was called BIALA. BIALA, it offers services for young people under 16, young people, not just under 16, young persons and also to adults, adolescents, and for children that have been exposed to a sexual assault or just exposed to anything to do with sexual assault. They offer counselling. They're a specialist service. They're also part of New South Wales Health. They offer counselling, and they're based in Gosford. It's a free of charge. It's a confidential service. Fortunately, they can refer to CAMS. If the young person comes over to sexual assault services and they feel there is an increased risk, there is a mental health component, they will refer directly to us. We will pick up the referral, work with the young person, get them from the acute point to a manageable point, and then we refer back to Biella. There is this constant discussion and open communication between sexual assault services and CAMS. So we work closely with them. And they are a 24-hour crisis center. They can also contact people during the afternoons and the evenings and the weekends. The next slide is about victim services, of what we call VOC services, victims of crime. They are a service, again, part of New South Wales Health. They offer trauma-focused counselling. They can offer up to 22 hours of free counselling, which is equivalent to 22 sessions. And that service is available for the primary person that's involved and the secondary victims, as well as family members. They work on rehabilitation. They have a clear focus on rehabilitation, and they are usually allocated to clinicians that are experienced in working with victims of crime. Again, we can refer to victims of crime. We can do the referral to them, or they can refer to us if they feel there's an increased risk, especially around safety with the young person. The next service is youth, drug and alcohol. Youth, drug and alcohol, these are a specialised service, part of New South Wales Health. They are located in Wyong. They offer counselling, they offer family support, they offer education to young people between the age of 12 and 18. They offer the counselling to those that have moderate to severe drug or alcohol concerns. They have also a harm minimization policy, or they can work with the young person depending what the young person goals or what they want to achieve from linking with the youth, drug and alcohol services. Their clinicians are experienced in mental health as well. Sometimes we get referrals for young persons that present to ED intoxicated or under the influence, or expressing some psychotic symptoms due to substance use. We will usually tend to say, go and liaise with the youth, drug and alcohol. In some situations, we will work with the young person, and then we will refer to youth, drug and alcohol, and we can do a warm handover from our service to the youth, drug and alcohol team. They're located in Wyong, and they're also Monday to Friday. A young person can self-refer, or a GP can refer directly to the youth, drug and alcohol team. Eating disorders, that's recently, I'm sure in the last 6 months, we would have had maybe over 10 young persons that have presented to ED with an eating disorder and a mental health component. In situations like this, we have to be very careful to make that clear, the discerning between, is it a mental health condition that's causing the eating disorder, or is it the other way around, the eating disorder as an eating disorder per se? There are 2 services that offer support for young persons with eating disorders. There is the Eating Disorders Outpatient Clinic, which is based in Torquay. That's part of New South Wales Health. It's a free service. Will offer support for the young person and their family with eating disorders. They will also work with those young people that are at risk of developing an eating disorder. They have an early intervention team that includes dietitians, social workers, and clinicians, and psychologists. They'll offer counseling to the young person. They'll offer counseling to the family. They will offer counseling on nutrition, dietetics, or information on body image and disordered eating. This particular service is free of charge. It requires a GP referral, or the young person can self-refer. And it usually provides community-based early interventions, and they're Monday to Friday. The other, with the one thing with the eating disorders outpatient clinic is there is a waiting period, sometimes can be up to 2 months, and some young persons, the situation is quite critical and they can't wait that long. In a situation like this, we suggest another eating disorder service, Myrtle Oak. That is a private service. There is a cost involved with it. It will require a GP referral. The young person can refer directly there, but they won't be able to get a Medicare rebate. If a GP does the referral, the young person can get a Medicare rebate. If there's no referral from the GP, the full cost will be charged, but they're quite good. They have the same clinicians there, early intervention team. They offer quite a good support service to the young person and the family. Family support services, there is 3 or 4 different entities under this umbrella of family support services. One of them is what we call RAPT, or Reconnecting Adolescents and Parents. These are brilliant service because they do outreach. So they go up to the house, they work with the young person and the families, and they work on improving the relationship between the family and the young person, and looking at strategies to deal with anxiety and issues that are happening at home. There is a waiting period for RAPT. Unfortunately, at one stage, the books were closed earlier in 2021. The other service we usually fall on is Interrelate. They also offer another range of services to the family, mainly to work on strengthening the relationship, avoiding conflict, and building a strong relationship between the young person and their family. They have a lot of programs which is directed towards connecting families with services in the community. Family referral service, again, it works for individuals and families, counseling, relationship support, and parenting. If at any time you need a bit more information or pamphlets or any leaflets about these services, please don't hesitate. Just give me a call and I'll be more than happy to send them out to you. Life skill services, this is for your group of young persons between 16, 18 or 20 or 24. They will usually work around supporting the young person with employment, disabilities, youth skills. You've got people like the Salvation Army, Parramatta Mission, Uniting Church, regional youth support services, which offer casework and referral services for the young person. Again, just give me a call and I'm more than happy to provide support for you. OzChild is a really important service because it provides support for the young persons who are unable to live with the birth parents. Usually these are in situations where there is DV in the house, where either parent is probably in custody, where there is quite a use of substance use with the parents, there is risk of neglect and abuse. OzChild is amazing in looking after these young persons and linking them with counseling, linking them with supports in the community. We've referred young persons to them a few times and they're quite impressive and quite effective. The last service I'd like to talk about, and that's quite important because a few GPs sort of call me and say, look, we've got this situation here. We we want to refer this young person and there's been issues at home. My first question was them, doctor, look, I really hope that you have done a mandatory reporting. Oh, what's that? How can we do that? Sometimes, and I know you guys are very busy and your time is restricted and your time is really valuable, especially nowadays. However, when you do an MRG or a mandatory reporting guide, it will take less than 3 minutes, and that's being very liberal. Usually it would take between 2 to 3 minutes to complete. And then it will tell you in the end, it will come up with an advice, either contact the child wellbeing unit or contact the child protection helpline. I know with the helpline, there could be a waiting period because I had to wait one time for around about 20 minutes, and I know GPs haven't got that time. There is a provision where you can leave your name and your number and they can get back to you. A lot of GPs are sometimes loath to do a mandatory reporting only because they feel nothing will happen and nothing will come out of it. Let me assure you, every single mandatory report that's done counts and is listed and is taken into account. The whole process is cumulative. So it's, let's say a GP will do a referral, Olivia from CAMS will do a referral, Dr. Kevin Tang will do a referral. These referrals are all cumulative. It will add up. And then it gets to a point what we call a rush level, risk of significant harm. When that happens, that's when the DCJ, Department of Communities and Justice, intervene and they start looking seriously into the family situation and into the risk with that young person. So don't hesitate to do a report because it adds up. Sometimes too, when I call the child protection helpline, I will get informed, yes, we've had several reports about that particular young person, which is very reassuring that the process is happening. It's not just, look, I'm not going to do a report because nothing is going to happen. Might not happen this time, but it's a cumulative process. So please don't hesitate, do an MRG, because the many people that do an MRG, the safer that young person will be. I've also included the New South Wales Child Wellbeing Unit contact number, the 1300. Usually the 1300 number, someone will answer immediately and take your details and take your concerns. The 132-111 number, there is a waiting period, but there is a provision where you can leave your name and your contact details and they'll get back to you. I hope I have been helpful with these, but again, if there is any concerns, give me a call on the mobile number. I work Monday to Thursday. Leave a message for me and say, look, Olivia, can you please call me back? I need some information on anything. And I'm more than happy to get back to you with whatever information you need. Thank you, everyone. Thank you, Mel. I'll hand over now to you, Mel, to hand over to Dr. Kevin Tang.
Thanks, Olivia. And over to you, Kevin. Just a reminder to everyone, if you've got any questions, please pop them into the questions box, and a copy of these presentations and the recording will be available in our education library after the event. Thanks, Kevin.
Hey, no worries. So I'm Kevin. I'm one of the psychiatric advanced trainee based in Central Coast at the moment. I'm also doing some academic teaching as well through the joint medical program in University of Newcastle of the Central Coast campus. So I do lots of academic stuff with teaching and also examining medical students as well on top of my clinical job. So I'm currently based in the acute care team, which we do have sort of teenagers coming through as well, especially during time of crisis. And I have worked with children and young people, mental health, quite an extended amount of time during my training. So I'm actually quite comfortable with discussing about kind of prescribing and also other sort of intervention that may help you guys. And feel free to sort of put questions in the chat as well. Let's make it as interactive as possible. And it's not me trying to sort of tell you what to do, because I know you guys are all very, experienced as well. And managing mental health conditions been quite sort of common thing, especially in general practice. I used to sort of be in general practice a bit as well, so I understand it can be quite a high burden as well, especially with the pandemic and restrictions. So my kind of like approach is for today's talk is to kind of look at the indications of starting an antidepressant or any psychotropics, and then monitoring it, and then other interventions that involve, and also reflection at the end. And it's a step-by-step thing where you kind of do your sort of risk assessment, and then also sort of find out what are the sort of appropriate treatment that you are sort of using to target every particular symptoms, and then what are the other support services that you guys have for yourself and also your patients. So and I have sort of put up some few cases, so we can look at them first and see, have your kind of like thinking brain going on before we kind of like finish up at the end of what do you think which is the most appropriate kind of like approach that we'll leave for these two case study today. So let's look at Michelle first. So she's 16. She presents to you with low mood and agitation, and there's a history of school refusal. And because she's been caught smoking at school, she was then suspended. Mother found that she's been occasionally self-harming as well, not sleeping much, and there has been intermittent suicidal thoughts. Yeah. And when you're sort of looking at case studies like this, I know that it's sometimes quite hard to get a full picture, especially in a short consult in a general practice land. But I kind of like go with the kind of essential parts before we can think about what interventions we do give. So we look at family history. So on family history, you notice that mom has postnatal depression in the past and she was treated with Zoloft. Father suffered from alcohol addiction and is now not in the picture. And there's always important to know about what are the kind of like history of suicide in family. So there's no family history of suicide, but there's previous domestic violence, which increased the sort of burden of the trauma and all the vulnerability that Michelle would have. And then after family history, you then look at what is her physical health as well. Because things that are reversible is always good if you try to optimize that as well. So her physical health wise, she's had childhood asthma, a bit of mild acne vulgaris that doesn't need any treatment. As you guys know, that sometimes acne treatment can cause a bit of sort of irritability as well, such as Fluoxetine. She had her period at 14 and it's been quite irregular, regulated by contraceptive pill. Previous iron deficiency anemia, she's currently corrected with iron tablets. But you also notice that there has been sort of a trending up of a body mass index, which with irregular period, you're probably thinking things like polycystic ovarian syndrome and other sort of things that might contribute to mood swings and also irritability, basically, that's already existent as a teenager. But given that there are other sort of factors, it probably make them more agitated. So, and then we look at risk assessment. So what are the risk factors? So we identified that there has been superficial cutting, but there's no suicide attempt, even though there's intermittent suicidal thoughts. She's brought up single parent. There was previous risk-taking behaviors, like she's, experimenting, tobacco smoking, and maybe possibly other illicit substances that we have not sort of asked about. There's evidence of conduct sort of issues. And then there's a possible untreated mood disorder if this has been lingering for quite some time. And there's definitely a lot of vulnerability that we can find out in the sort of family system that we've just sort of dived into. So I guess looking at that, then you kind of want to look at what are the indications of pharmacotherapy, which we will kind of talk more after we look at these cases. All right, so let me go back to the main. Sorry, it's a bit repetitive with the slides because I want it to be as savvy as possible. So this is Patrick, our second patient. So he's 15. The parents brought him in because they noticed that he's been isolating a lot at home, not going out. And he used to be quite bright, but his academic results been slowly declining. And he spent time on mostly on his gaming consoles and also internet, basically, which is quite a lot of you know, the people these days, especially with the pandemic. It's cutting off the tech can be quite hard, especially with coming out of the restriction. And of course, with that, you'll have disrupted sleep schedule. And he's had nightmares before, but it's been becoming more prevalent these days. And he's also somewhat awkward at school. So there's been a bit of that kind of concern about maybe is he on the spectrum or kind of thing, which is quite a high sort of prevalence, especially in adolescent, especially when they're trying to sort out where they fit in into the mold. You know, things like gender dysphoria and lots of those identity, sexuality, they're just exploring that at the moment. So it's also important to, I guess, you know, go at your own pace where the patient's comfortable to kind of explore a bit more. So family history, so older brother has ADHD, and he also has a younger sibling, which is tested for autism spectrum. So all of the kids are cared by grandparents because obviously there's some child protection issues when they're younger. So it's shared custody between parents with supervision. So vaccines involved, and when you see this GERD involvement, it's kind of like a previous history of probably sexual kind of incident or trauma that has been involved. So it's something that if Olivia has already touched upon. So it's basically you need to be more aware about things like trauma and also the complexity of their kind of coping strategies as well. And then you look at his physical health. He's had a trial of Ritalin by his previous pediatrician, but he stopped it on his own because he did not like taking medications, as a lot of our kids or teenagers are a bit reluctant and their compliance is not that reliable. But there's no other drug use, and because of he's been isolated at home a lot and doesn't go out to do sort of physical activities as much, there's been previous blood tests that showed low vitamin D. But otherwise, he's quite healthy. So looking at the risk assessment as well, you know, obviously we have like previous trauma that we've highlighted earlier with the different sort of body involvement of the sort of governmental organization. And then there's possible and undiagnosed behavioral condition. So basically we have to kind of look back, is there any history from the pediatrician that have seen him in the past that prescribed him the Ritalin, to kind of like sort of see if this is a continuation of that. And then there's family history, strong family history of ADHD, conduct sort of disorders, and also autism spectrum. And then, you know, the risk between obsession and addiction that we notice with his gaming and internet gaming disorder has just been classified as a actual disorder on the World Health Organization International Classification of Disease. It's not on DSM at the moment, and there is reasons for that, which I'm also part of a big sort of research topic about internet gaming disorder at the moment, which I can come on next time if you guys are interested. So there's previous history of non-compliance and there is functional decline. And functional decline is really important to pick up, especially in teenagers, as you notice with schoolwork, important relationship. If that's starting to impact on them, it's better to sort of get some intervention sort of in place. So that's Michelle and Patrick. So just give you guys some time to kind of look through and see, are you guys going to start medication, or what are the sort of things that you worry about, and then we'll come back to that. But now we'll go into my main kind of discussion, which is more of the clinical part of things. So is there any sort of antidepressant or antipsychotic that you guys use a lot in general practice? And I know that there's a few common sort of medication or that you guys use, but we do use as well, and we continue using them in psychiatry as well, even after referral. So, but I guess before we jump into the clinical side of things, it's important for us to also check the checkers, basically everyone in healthcare system, because sometimes, you know, we put so much effort into things and we just need that extra validation as well. So we need to support each other. So there's a few resources that you guys can go into, like there's doctorsfordoctors.com, there's the Shift app for JMOs, and then This Way Up as well. Then Are You Okay? Basically, you know, just check in on your colleague as well, and just to start a conversation if there's any sort of stress going on. This is Shift, which you can actually download from your Google app or Safari store to kind of like have a little guided sort of meditation and all the other topics that is helpful for mainly like for junior medical officers. But for the doctorsfordoctors.com, it covers from medical students towards retiring doctors. So it's something that it's great that there's been more acknowledgement about the burnouts with doctors and also healthcare clinicians as well. So we are prioritizing our own sort of group. So we have to be vigilant as well of our own mental health. All right, so let's look at the pattern of use of psychotropics, and this is from the Australian Bureau of Statistics in 2011. So I'm excited to get the new statistics soon in this year. So looking at the 10 years ago, so as you can see, 1 in 7 Australian has at least tried an antidepressant, or at least have one antidepressant script dispensed. So that's actually quite a staggering number compared to, you know, most of the other chronic medical condition that we have. As you know, that the mortality rates for mental health condition has kind of climbed up the charts as well. And particularly in the Northern Sydney and Central Coast Local Health District, as you can see, back in 2011, there's the population here that use about 6.6 amount of times compared to all other people in Australia, which is 5.2 times. So we are a bit more of a increased rate of sort of mental health comorbidities as well. And unfortunately, you know, there has been history of domestic violence being quite prevalent in Central Coast among all of New South Wales. So I guess that's just reflective of as well of these numbers that we do sort of look after a more sort of vulnerable cohort as well on the Central Coast and Northern Sydney. And I'm sure Hunter, New England is not far from that number too, as I've worked in Tamworth and I've noticed that too. And from the statistics as well, the females are more likely than males to have had prescription for antidepressant. As you know, that male are less likely to kind of like self-present or to seek help because of that ongoing stigma that we still have with reaching out. But definitely over the years, I've noticed there's a more kind of motivation to actually seek help as well. And with that also, we just need to be aware of not over pathologizing, you know, mental health. And a lot of the sort of struggle that we have is quite part of the life challenges that we see. So this is just another chart from the Australian Bureau of Statistics showing that what are the proportion of people assessing Medicare or the PBS mental health related services or medication in 2011. So as you can see, there is slowly a creeped up sort of numbers in our teenage population and younger children. And obviously, as people age, there's also more demands as well. But it's important that we start when their first interaction with mental health service, we start them right. So it's helped them to kind of like reach out as well when they reach a later stage in life. And these are the sort of services that they go through, like obviously GPs being the first line, that would be the main sort of the pathway, and then referral to psychiatrists. About 50% of them get referred, and then there's other shared 50% that goes to clinical psychologists or other psychology kind of services. And as you can see, antidepressants still pretty much the most prescribed psychotropics among all the others, especially with the sedative and hypnotics being more restricted with the sort of schedule prescribing. And antipsychotic has kind of been steady and has not changed much because of the detrimental side effects of especially in the teenage population. There's definitely neurovegetative side effects as well, so we tend not to prescribe antipsychotics, and the psychostimulants is still kind of like least prescribed among all the psychotropics. All right, so before we jump into the pharmacology of things, it's always important to make sure that the first line is always used. So things like psychological intervention, online therapy, school counselor, all the other sort of aspects is being utilized as well. So it's also important that we ensure the safety of the young person in the environment where they're staying. That's why Olivia mentioned about the child protection sort of conditions. And then it's important to remember that we're not just treating the young person, we're actually treating the system as well, which involves the family, the carer, and the whole organization that is involved with the young person. And also remembering, their vulnerabilities that might make the recovery a bit more difficult as well. So these are the things that usually we try to advocate for before sort of looking at medication as well. For example, things like CBT or the mental health care plan, you can try that bulk bill psychology sessions, or victims of crime, if you're concerned about trauma, they can apply. And obviously with the demands of psychology going up, the waiting list is quite high up there. So that's why online therapy has been a bit more accessible. And then obviously the more face-to-face things at school. And yeah, basically these are the things that you want to look at before considering medication. So the indications for pharmacotherapy, as you guys know, if there's a strong family history that kind of sort of puts the patient at a high genetic vulnerability to get depressed or anxiety or sort of psychotic illnesses, you just have to kind of like be aware of these sort of factors. And then in teenagers or young people, we usually give pharmacotherapy in moderate to severe depression. And in that meaning is that where they have a length of where they tried psychological intervention and still did not help, or you tried sort of modulating the environment in where they're living, and that still is not sort of making them be curious and wanting to learn and do their usual thing as a teenager. And their functions decline as well, then that's where you look at probably it's a moderate to severe depression, after also eradicating other reversible conditions like thyroid, or if their sleeping is affected, there's possible like sleep apnea, or is there anemia or any drug induced, especially with stimulants and also other substances. And there's also things like ADHD or vitamin D or any B12 deficiency, lots of different things that we can sort of check. And then sometimes the kind of like cutting point for GPs to look at medications, psychotropics for the young person is basically if they tried regulating their sleep, like with melatonin and still not helping, then maybe it's time to look at a more kind of active ingredient to help with the mood and also anxiety. So the principles of prescribing in young people, as you know, it's different than adults where we're looking at a sort of a population where their organs and everything are still developing, and you have to sort of look at the weight and how are they looking like adult size or not, things like that. But also the things is we're not looking for diagnosis at such a young age, because it is where we kind of look at different clusters of symptoms, and also they're still figuring out what their personality would like to be, and also where they fit in the role. So it's hard to kind of put up a diagnosis in the first few sort of consults that you have for them, but you can always suggest that things like there's early signs of, for example, borderline personality, or early signs of things like antisocial, such as conduct disorder. So it's more about targeting symptoms. So you're looking at if they're having low mood for extended period of time, maybe that's the thing that you want to target. Or if they having problems with sleeping, that's probably another sort of set of things you want to target as well. If they're suffering from amotivation or sort of lack of appetite, or things like eating disorders, things like that, you might want to sort of go down that pathway rather than sort of putting on a diagnosis for them. And with medications in young people, always start low because they're quite sensitive to the side effects of the medication. And sometimes, because as you know, that the adult liver is quite big, and if teenagers, they're still growing, so there might be a bit of a fast metabolizer as well. Sometimes I tend to have a bit of a breakup of the antidepressant as well, like morning or afternoon, sort of, rather than having it at one dose, because it can take time for it to be metabolized, or sometimes it doesn't stay in their body as much. It gets excreted quite quickly, and allow time for the medication to kind of work in the system before trying to change it. And always change one drug at a time, because sometimes I get a cocktail of like a patient comes in with a cocktail of a symphony of antidepressants, and it's hard to kind of like, oh, which one should I cut first, which one should I sort of target to sort of augment or modulate. So it's always one drug at a time to change. And withdrawal is actually very, very agitating for them as well, especially when they're in teenage life. And monitor outcome as well. So you can use different scales, like there's the K10, or there's the anxiety, Beck depression scale, lots of different scales that you can use to just sort of monitor. I think they do that for the GP mental health care plan, where they have inventory for checking your scoring of your low mood, and then sort of do it at the end of your mental health care plan and see if that's any sort of improvement. And then also when you're prescribing, it's always important to sort of educate the patient and also the family of what to expect, basically, like, oh, you're not going to expect a quick fix. It's more like something to help you to balance your chemical imbalance in the brain while you're doing all the other things like psychological, or sort of getting sort of school intervention in place. It's a mixture of everything. And what I like to usually use to explain to the young people, like, imagine the antidepressant is like something like a coffee. When you drive, the coffee is not gonna sort of drive the car. You still have to drive the car. The coffee that is there to just give you that little improvement of your concentration, while there's that guide over there, which is either your GP or psychiatrist or psychologist, that's going to help you navigate around the road. And you can't control the roadside conditions as well. So it's something that we'll both, look out for you, and you also have to look out for yourself. And then once you learn that experience, then you'll be a bit more confident in going through that sort of roadblock or any other kind of speed camera or things like that. Not encouraging anyone to speed. But yeah, it's just a little analogy to make them understand better. And that's like a really good psychoeducation that I use for parents and also for the young people. So next is, but what about anxiety? So I've spoken more about depression, especially in teenagers, but with anxiety, it's always often improve with age. Sometimes psychological intervention is sufficient, but also we need to exclude other diagnoses as well, as you pretty much will have an influx of people feeling panicky and also anxiety sort of hitting. I'm anxious now talking as well, so you just have to sort of see what's normal, what's abnormal. And then there's always, as usual, lots of different baseline checklists that you can sort of use. And always remember that if you're thinking about prescribing a psychotropic for anxiety, it always takes the longest compared to mood disorders. So it will take some time, especially with the anxiety people. They're a bit more on the neurotic side. It can be quite triggering for them to know that it will take longer. So it's always important to let them know first when you start, so that they don't have this expectation where, it'll kind of like work quite quickly or rapidly. So that's the more important part of the psychoeducation. But what about psychosis and mania? So with these kind of condition, it's actually quite rare in the younger population to get mania and or psychosis. I know that there's the prodromal era sort of times for teenagers to, if they are going to develop like a psychotic illness in their early adulthood. But it's something that you'll then look at family history, and then look at if they're in the ultra high risk population. Then you can look at sort of trying to prevent that by teaching them to abstain from drugs and alcohol or any other sort of neuro-changing substances. And most of the mania or the sort of abnormal behavior, it's always short-lived episodes, which it happens in teenage life, where you get into conflicts and then you're trying to sort of process that sort of emotions. And it can cause sort of an abnormal reaction, especially when they don't have their frontal lobe fully developed yet. So they can tend to be more impulsive as well. And it's always associated with things like conduct and other primary mood disorders before you think about things like bipolar or schizophrenia, especially in young age. Things like trauma, anxiety, and also sort of autism spectrum as well can sort of give you a bit of that abnormal sort of, like with ASD, they feel very sensitive to lots of different things, like white noises and things like it's there, but it's just overstimulating for them. And trauma as well, that reliving, that sort of you get a bit of that pseudo hallucinations as well. So just need to sort of have a clear understanding of the different sort of hallucinations and what's a more like a primary psychotic illness hallucination. And obviously substances or people on steroids sometimes do have these reactions as well. So just have to make sure that you've done a collaborative kind of like systems review. But what are the other kind of like factors that pushes us to actually prescribe antidepressant or any psychotropics in general? So obviously there will be parents' pressure, which we do understand. And also we just need to sort of hear them out and also understand why they're feeling that they need to have their kids on these medications, and explain to them why we're a bit trying to safeguard the kid from exposing to early use of psychotropics. Sometimes the kid might request as well, especially with internet being widely available at these days. They probably sometimes, have researched it, or they have peer pressure. But being that it's 1 in 7 Australians on antidepressants, so even in the school sort of culture, they'll be more happy to talk about what medications they've been on, and they might want to just, follow the trend. And so just understanding the reason behind the patient's request as well, it's quite important. And then there's school's pressure because of, the violent outbursts and all that, which is understandable as well, as long as you, discuss with the school, or go through school link, which is what I recommend if you sort of refer on to the acute services. There's also things like the NGO's pressure as well. But all in all, just have to focus on the patient itself, and try not to be sort of pressured into actually writing that script pad, especially when if it's not indicated. Then you should just trust your instinct and document basically the reasons why you're not prescribing. So like I said just now, when you're prescribing, always talk about initiation period, and it's not going to take the instant sort of happy pill to work instantaneously, and there's always limitations of these medications, and every time you start a medication, there's always a higher risk of things like, as you know, with suicide and things like that. But it's more important to treat the untreated psychiatric condition, and that sort of weighs in the benefits and risks, and the benefits definitely outweighs the risk. But just letting them know that given the initiation would increase their sort of serotonergic surge and all that agitation, it's important to start it at the right timing where they feel supported and their environmental sort of factors have been addressed as well. Explaining to them about the mechanisms of action as well can be sometimes helpful, like how I sort of explain it with the chemical imbalance in their mind and things like that, to kind of have them a bit more sort of informed consent of what they're going to use, and understand their sort of perspective as well. And also discuss about possible adverse events as well, such as nausea, vomiting, or other things like brain zaps during withdrawal, different things, interaction, if they're on blood thinners as well, it might increase the risk of bleeding and all that sort of situation. And also if they're using substances or alcohol, basically, it does interact, because alcohol is a depressant itself, so it's not going to work really well with antidepressants. So things like that, it's important to let them know if they do plan to drink, then you just have to explain like what are the possible interactions. So how to sort of use antidepressants safely. So mainly, I guess you guys will know that, like I said, start low, go slow. Especially when they're sensitive, always go a bit slower with increment. And you also have to understand like the are they in tablet form, or are they in capsule form as well? So that will affect the way you want to increase it gradually in community. And then after you start it, it's always important to have a sort of follow-up appointment set up. That's usually in my setting as well. I do follow up after starting someone on antidepressant as well, just to make sure that if there's any side effects or if there's any question, they can be addressed during the next session. So this statistic is a bit 1 in 3% out of 100 children has reported suicidal ideation during commencement, which is quite common thing, especially when you're sort of changing the chemical in the brain, but your mind is still in a dark place. It can sort of surge a bit of that. But as like I said, potential of untreated depression risks outweighs the above risk as well. So it always benefits if we treat the depression, and they'll get better in the longer term. And if you feel like even after you started this, you increased it to a maintenance dose and it's still not working, and you might want to think about maybe it's time to switch. And mainly I would say about 2 to 3 months, it's kind of like the time frame for you. But if they do well on the antidepressant, then you would probably stick to that dose for at least 6 to 12 months, as long as there's no upcoming kind of transition in their life or things like that that might sort of rock the boat. Then I would sort of gradually cut down, and be also sort of giving them education about possible withdrawals. And also, as you know, things like serotonergic syndrome and NMS. So you just have to beware, do a medication review if they're on things like tramadol that will increase the seizure threshold, if they're on any SSRIs. So things like that, just have to be a bit aware. So these are the things that I tend to sort of avoid to use in younger people. So things like tricyclics, like amitriptyline, imipramine, or nortriptyline, that they're all more reserved for like the third line of depression, used mainly in the older generation. The reason why is that there is limited evidence of tricyclics being useful in the younger population, and there's actually more harm, especially with their developing cardiac system, and also neurological system as well. So it can sort of tamper on that. So that's where I tend not to use the tricyclics at all. And the risk of overdose of tricyclics is actually quite harmful, especially in a group where suicide attempts could be a bit more common compared to the older population. Paroxetine is a antidepressant that is very quick to sort of come out of the system. So it has the shortest half-life among all the antidepressant. So it's something that I avoid using because, as you know, withdrawal on a teenager is definitely not the best combination. So that's when I don't use it, unless if it's purely for things like erectile sort of sexual sort of side effects, because they have been useful for premature ejaculation. But if they're gonna be on any antidepressant, they'll have that side effects anyway. SNRI is another thing that I tend not to use unless they have finished up all the first line antidepressant, because they do have other sort of side effects as well, especially when you're just sort of blocking some of their noradrenergic pathway as well. So you have to monitor their blood pressure and lots of different things that you have to monitor, especially if they a bit anxiety sort of prone as well. They might have palpitations, all that. They might present a lot, and yeah, just avoid those SNRIs in kids. St. John's wort obviously interacts with every psychotropics. Maui, it's an old generation antidepressant, so that's something that I would not use as well, because it interacts with lots of thiamine food, which a lot of people do still consume a lot, like cheese, and any kind of addictive prescriptions such as benzos or Xanax, or things that might make them not cope, and just focusing on those short-term sort of release. So now we're looking at different first-line antidepressant. So as you know, fluoxetine is the recommended first line. It's FDA approved, and it's also approved in Australia as well. Has the longest half-life, about 35 hours in the system. So it's usually be given in the morning, or alternatively, you can give a morning and noon. The starting dose is always about 10 milligram when you start, and then you gradually increase it as you feel like if it's responding clinically. But the thing is, it does taste horrible in the tablet form. I've had a lot of patients just not compliant with it with the tablet form. So mainly you go with capsule, and even then they still have that bitter aftertaste. So that's something that I've feedback from my patients, that they really struggle to sort of swallow this pill. But otherwise, once they're in the system, it primarily targets, if you're lack of energy, if you're not motivated, and basically it's a very energizing antidepressant. And if there's any liver issues, you tend to lower the dose a bit as well. The next one is also FDA approved and approved in younger PBS as well. It's citalopram or Lexapro, and got other brand names as well. So the half-life is about 27 to 32 hours. So slightly shorter than fluoxetine, but you can start them from 5 milligrams to 10 to 20 milligrams a day. And the thing is, I like Lexapro because they come in liquid form as well. So if people who have trouble swallowing, it can actually help them, and you can add it into any clear fluids like apple juice and things like that, and that would be more sort of compliable for the younger population. It's comparable to the citalopram. As you know, they don't have that active isomer in citalopram, but citalopram is actually not approved to be prescribed in younger kids. So I usually just go for escitalopram rather than citalopram, and it has fewer side effects as well. But the thing that is quite notorious in my sort of experience is that patients do sort of disclose nausea and insomnia upon initiation. So usually I do it in the morning rather than nighttime. And they always go with food as well, so to reduce that sort of that nausea basically. So in the long run, it does help with anxiety, and also does help with sleep disturbance. It tend to sleep a bit more after they go on it in the morning, and also helps with low mood as well. So something that you can think of using. And yeah, like I said, morning dose recommended. So citalopram, like I said earlier, it's off-label in pediatric use, but if you do come across patient that's on it, usually 10 to 40, nothing more than 40, because above 40 can cause ECG changes, so you get QTC prolongation, so it's probably quite risky to be used in especially younger kids. It's maybe more tolerable, but it's just can be quite sedating as well. So next, the other quite common antidepressant that I've seen as well, Zoloft or sertraline or Aleva. So it has about 22 hours of half-life. These are based on adult, so they might be a bit different because there has been limited evidence of a generalized pediatric population with half-life of medication because everyone's different. So we just go with a more generalized in adult sort of pathway. So with sertraline, it's a more gentle antidepressant compared to fluoxetine, which is more energizing. And sertraline, you can use it for OCD as well as also for sort of trauma sort of history. They are quite useful, and it's kind of like my go-to medication if they're pregnant as well, because it doesn't sort of cause any malformation like paroxetine does with the fetus heart. So usually I give it in the morning. So in children, I usually start in 25. But if they're like teenager, I'll probably start with 50 and then slowly sort of gradually go up and see how they go. And they primarily target is the obsession, the compulsion, and it's also good for mood. And in the long run, of course, it can help with anxiety as well. Obviously, it cross reacts with tramadol a bit more readily as well, given the interaction with tramadol. So this is another one, fluvoxamine, which is also SSRI. It has up to 28 hours of half-life, and usually I give this in the nighttime dose. 25 milligrams as well if you're starting in children, but if you're starting in adolescent, you can start with 50 milligrams. It's also focused on, giving that targeted symptom of obsession or ruminative thinking, especially if your mind can't turn off at night. I tend to go with this option as well. And people on the spectrum as well, I've noticed that I've given this medication and it does help with them as well. But also because it can be quite sedating at night, so usually I give it at night if they have any sleeping issues as well, but not as strong as mirtazapine though with their sedating effects. But you have to monitor the liver and the renal function as well. And there has been recent studies that fluoxetine, because of it has some alpha-2 receptor agonists, it has sort of proven that it's prevent people with COVID-19 positive to then sort of end up in a serious complication as well. So it's something that's been studied in various countries, but don't take it as like a Bible and wait for more of the evidence to come through. But so far, apparently, it's quite promising. Hopefully, I don't see a surge of fluoxetine. Next is mirtazapine. Little evidence for mood and anxiety for younger population. It's usually, I only prescribe mirtazapine if there is something to do with their sleep is not great, even with melatonin on top of the antidepressant of choice that you've used from the earlier slides. So mirtazapine is something that I might think if sleep is the main thing. But you have to know that they are notorious of weight gain. And if they are a bit sensitive with weight, you might want to put them out there. But sometimes I do give, the irony is that, if they have tendency of eating disorder and things like that, and they're not sleeping as well, this might be a good drug of choice. But having to disclose that you might gain weight might distress them a bit. So you just have to sort of look at alternative antidepressant first. And if that's still not working, then you might want to look at this option. So lower the dosage, the higher the sedative properties. It's because of the antihistamine component in mirtazapine that sort of sails through more at lower dose compared to the serotonergic and also the adrenergic receptors as well. So for this one, you start at 15 milligrams at night. Obviously, for younger kids under 12, you start with 7.5. They come in tablet form. So you can start it that way and slowly. The maintenance is usually at 30 milligram, and you can go the highest for them, it's 60 milligram, but never higher because it will make them more agitated. So like I said just now, if you're thinking of a SNRI, it's still yet to show robust efficacy in clinical practice, especially for the younger population, and you do need a bit more monitoring compared to the SSRIs as well. So always exhaust your first line before going on SNRI. Or if you feel like there's chronic pain or neuropathic pain involved, then sometimes I do give things like duloxetine because it can help with pain, like chronic pain causing sort of mood changes, especially with lots of sort of people with congenital sort of issues. But it does have evidence of increased agitation in teenagers. And if you're considering SNRI, consider referral to psychiatrists or the acute care team, and we can sort of talk about further sort of recommendations. But if you're thinking of augmentation as well, so it hasn't been studied much in children. It's mainly augmentation in adults. And in clinical practice, usually we give things like antipsychotic, atypical antipsychotic, or lithium, which is suicidal prevention. But if you're considering starting lithium, then you will need blood monitoring as well. And if they are in a sort of childbearing age as well, it might affect them as well, especially if you're thinking about things like epilim, seizure threshold as well. And it's difficult to maintain as well if they're in the compliance is not reliable. And as I said, you feel free to talk to us and refer if you do feel like the first lines and psychological intervention is not working, and if you want advice about augmentation. So antipsychotics, like I said, it's usually off-label use, non-PBS, especially with the current sort of the population with the younger people. The reason why is because it does have a street value, and people can actually buy Seroquel or serotonin, quetiapine in the market street. That's why sometimes I'm a bit hesitant to give to young people as well, because they might share the pills like what they did with Ritalin in school in the past. And it's usually only short term if you're thinking of a non-psychotic illness sort of augmentation. There's definitely risk of stunting the neurodevelopment pathways in the brain, especially with the dopamine sort of blockage, and also if they're using drugs as well, it's maybe enabling them to use it more, which further sort of disrupt the sort of neurological cognitive development. So it's something that I'm very careful of before I prescribe. And I know that there's been a surge of quetiapine use from emergency, but as usual, that's only for short term and should not be sort of put as a long term. And usually we only use that for sedation purposes as well, and to take the impulsivity out of the picture. So yeah, so takeaway points, like I said, psychoeducation combined with psychological intervention, always target symptoms rather than diagnosis, have a safety plan when you're sort of discussing about starting a antidepressant, where to go when you're suicidal, who to talk to, and what are the things that make you feel safe. And then if there's any concerns of, things like autism, ADHD, refer to peds, or if you feel like there's some endocrine sort of imbalance as well, feel free to refer. Or like gender dysphoria as well, you do need, endocrine involvement, or refer to psychiatry sort of services, and also other practical school support or online safety. Talking about contraception, also drug and alcohol involvement can be helpful for the kids as well. So I guess then we look back at our cases. So what do you guys think would be helpful for Michelle? So psychotherapy, yeah, we've talked about that. Family therapy, school link because of a school refusal. And then given that she's smoking as well, maybe we should sort of talk about it. Is she smoking it because of she's already tobacco nicotine dependent, or is it just more like a trend? And then sleep hygiene education as well, and also addressing metabolic risk factors because there's concerns of polycystic ovarian syndrome. So for her case, I would say, after doing all the other things, if she's still having trouble with all these symptoms, not sleeping much, intermittent suicidal thoughts, there's a few options that you can look at. You can look at family history as well, because her mom's been on Zoloft. So there's something that you can think of trying, and then see how that goes. But otherwise, there's a lot of other options as well in the first line that you can use. Obviously, avoid anything that will increase weight gain, like mirtazapine, because she's already at a kind of like at risk with the sort of irregular period and things like that. So how about with Patrick? So as you can see, need to try some psychological therapy, clarify ADHD or ASD diagnosis, get some input from pediatric, probably need some trauma counseling. And then if it's safe at home with the grandparents, is there any people abusing him as well still? Probably want to supplement the vitamin D. And then sort of trying to transition him back to school. And then also maybe talk about the sort of having a boundaries with the internet use as well, and the reward system, that might help. But if that's still not sort of helping, you can always look at, you know, things that might help is, you know, sleep schedule and nightmares. If there's that tendency for ASD, I can look at starting fluoxetine as well, because you seem to be quite ruminating on stuff as well. So that's something I can think about. Yeah. So at that note, I can answer questions later, but these are my resources that I've taken from. And thank you for your attention. And hopefully this has helped you sort of have a mindset of how to approach these situations. All right. Thanks, Mel and Olivia, for inviting me here.
Thanks so much, Kevin. And we'll now hand over to Erica.
Thanks, Mel. Okay, I'll just confirm that you can see my slides.
Yes, all good, perfect.
Great. Okay, so yes, I just wanted to cover the relevant pathways that we have on our Central Coast Health Pathways website that relate to this topic. So I'll just provide a quick summary. So we've got the login details there, the web address and the username and password for Central Coast Health Pathways, and that's designed for health professionals only. And then we have the companion website, which is called Central Coast Patient Info, and that's publicly accessible at that web address, and that's suitable to be provided to your patients, and the general community can access that. So just a quick summary of what Health Pathways is. So the program provides a website, and the Health Pathways program is a process that we work with primary, secondary and tertiary care providers and subject matter experts to systematically improve care between the sectors. And we provide the website, which provides an online decision support tool for primary care providers to use during consultations. And it provides locally agreed information on assessment and management of conditions, and also the local referral options and contact details for those referral options, and provides clarity on the services, the criteria, who can access them, who provides the services, and where and when they're provided. So this is just a screenshot of the homepage. We've recently published the ADHD in children and youth pathway and ADHD medications for children and youth, which is particularly relevant to this topic. So I just wanted to highlight that those recently were published. Okay, so the clinical pathways that are relevant to the topic that we're discussing tonight. So we've got quite a lot of mental health pathways now localised. So we've got a range of pathways specifically for children and young people. So just some examples: anxiety, depression, OCD in children and young people. As I said, the ADHD pathways that have just been published recently. We've got specific youth mental health page, self-harm, suicidal ideation and intent pathways, eating disorders, psychosis, and that includes specific page covering the antipsychotic medications and adverse effects. Physical health and mental illness as well, so the risks in terms of the physical health of the person with the mental illness and the effects of some medications on their physical health. We've also got a resource page called Mental Health Stepped Care that we recently published about the different levels 1 to 4 of stepped care across the whole health system, from low intensity right up to the acute mental health services. And information page about scheduling a patient if needed, and then some other related pages such as behavioural concerns and out-of-home care, for example. So these are all hyperlinked, and the slides and the recording will be up on our education library, as Mel said. So you can just go straight into these slides and click directly to those relevant pathways. In terms of the referral pages, so we've also got a lot of mental health related referral pages localised now. So we've got urgent pages and then also the non-urgent pages. So for example, psychology and counselling, specifically psychologists that focus on seeing children and young people. We've got the community mental health pages, so they're more of the non-government organisations that provide non-psychological and non-clinical support, more of that social support and family support. We've also got summaries of all of the online mental health options. That there's a lot of options now available for online CBT, for example. We've got the information about access to funded psychological services, so that includes information about the PHN commissioned providers such as Coast and Country Primary Care that provide funded psychological services separate to Medicare for particular vulnerable priority populations. We've got eating disorders referral page as well, the helplines summary page, so lots of mental health helplines are available now, so that's a summary page of all of those. And then the advice lines as well for clinicians. So the PHN commissions a provider to provide psychiatry advice to GPs, and then there's also the local health district as well who can provide phone advice to you. We've got a specific page at the moment related to COVID-19 mental health supports that are available for your clients. We recently published the social prescribing support page as well. So obviously there's been an increase in isolation during the pandemic. So there's a page there that covers services that might do phone check-ins for people and other social sort of support providers, non-government organisations. And then just a couple of other examples like the behavioural assessment, child protection reporting, as Olivia talked about earlier, and then also the allied health and nursing referral pages as well. So yeah, this is just a screenshot of the patient info homepage, and we've got some specific pages related to COVID-19 as well, and quite a lot of information about mental health on patient info. And if you need to contact us with any more information, please feel free to contact us. We've got a page on Health Pathways about how to contact us, or just phone our team through the PHN. And as always, we would love to receive any feedback that you have to improve Health Pathways as well. If you want new pathways localised, or you have any updates or suggestions, please use the send feedback button or send us an email to that email address there. The send feedback button is on every page of Health Pathways in the top right corner, so feel free to send feedback and we'll endeavour to improve Health Pathways as always. Thank you.
Thank you, Erica.
Thanks so much, Erica. Thank you. So we'll hop now to the questions. There's a couple that have come through. There's lots of positive comments about tonight's webinar, so thank you for all that lovely comments that have come through. And just a reminder that a copy of the presentation and a recording of the seminar will be available on our website in the Education Library. So just a couple of the questions that have come through. What assessment inventory would you recommend for young people was the first one. So maybe over to you, Kevin, for that one.
Sorry, come again, what assessment?
It just says, what assessment inventory would you recommend for young people?
So there are heaps of different assessment sort of inventory. So just go with the usual one that you are familiar with, and we can always gauge with your referral from that inventory that you are familiar with. So we are quite open to any inventory referrals that you send through. We just have to have like a baseline so we can actually use that inventory at the end of our kind of like involvement to kind of like refer to. So anything that you're comfortable with, as long as it's within the kind of like health organization.
Okay, the next question's in regards to sleep medication. Is it melatonin? Am I pronouncing that correct, Kevin?
Melatonin, yeah.
Yeah, does not work for your patient. What would you do or likely to use to assist with sleep?
But it's just solely for sleep, is that right?
Yeah,
Yeah.
sleep medication.
So I would go, there's still rooms for the melatonin. Like it's not just, I know it's an expensive medication because it's not PBS. It starts with 2 milligrams as well. So you can go all the way up to 6 to 8 milligrams, but do be aware that it can cause a bit of a headache upon waking up. Because in the end, it's not a sleeping medication itself. It's not a hypnotic. It's more of a supplementary to regulate your circadian rhythm. So it's more like a sleep hygiene kind of sort of stimulator, as well as the other things that, limit phone screen times or activating activities before bedtime. The other non-pharmacological things like meditation, if people want to use ASMR, these are the things that people have been using as well. Weighted blanket is another thing that if you have a child with a complex trauma history, I've noticed them using the weighted blanket, and that sort of take off a lot of that sensory and they feel anchored, and that would sort of help them sleep as well. Sometimes short-term use of antihistamines has been used, but I don't advocate for long-term use, especially like, it's used for shift workers in adult population. But in child, especially when they're so sensitive to any pharmacological intervention, I would always, don't sort of rely on the pharmacology sort of intervention, especially with things like benzos as well. Definitely, I wouldn't start. And I know lots of parents sometimes, thought that they might give their own medication to their kids, but sometimes it's just giving them that wrong sort of habit that they will just, oh, if I can't sleep, just use a pill, So there are other things to kind of like recommend before going to like the hypnotics as well. Yeah, if that
Okay,
answers my question.
that's great. Thank you so much. There's also a couple of questions in regards to the age, the youngest age that you'll be prescribing some of these medications for. What age were you looking at? What that would be the youngest?
You mean based on my clinical experience?
Yeah. Yeah.
Yeah, so I have seen people as young as the age of 8 or 9 started on antidepressant, but sometimes it's just based on the family history and also the things that you tried before going on medication. So there's no cutoff age as long as you know about the weight and the kind of different antidepressant and how they sort of get metabolized in your young person's sort of body. As long as you be a bit more mindful that you need to start at a lower dose. And also if you're thinking about starting on a younger patient, obviously always involve the pediatrician or a child psychiatrist to sort of cover yourself as well, because you don't want to get like angry patient that sort of come back to you and said you initiated the process and now this young person's on a cocktail of medication. So it's always good to get yourself covered with other sort of involvement of pediatrician as well as psychiatrists. But mainly the antidepressant that I've seen started on kids are more of the first line ones, and sometimes if they have diagnosis such as ASD, they can be on low dose of risperidone, but that's something that's probably, you do need to have the PBS approval, so probably get a specialist to initiate that. And then if you're continuing it, that's fine, but never initiate like psychotropics on young kids if they're not indicated.
Okay, all right. Well, thank you so much for that. And thank you to Olivia, Kevin and Erica for being with us this evening. It was really great content there and lots of information, and which is wonderful, especially at this time. So really appreciate your time and being with us this evening. So thank you again for that. And just a reminder to everybody else that the poll will pop up at the end of the session. So we strongly encourage you to please complete that. Thank you, everybody. Have a lovely evening and stay safe and well.
Thank you.
Good night.
Mel.
Good
And
night.
look after yourself, okay?
Thank you. Thanks, Kevin. Bye.
Bye.